Hi, I'm Jake Grez, also known as Nurse Jake. As a travel nurse, I've worked in all kinds of places, different settings, cities, and climates. Every assignment brings on a new challenge, which is why I always bring my figs. These scrubs are built for whatever the job throws at you. They're breathable, flexible, and comfortable in any environment. No matter where I land, I know they're going to keep me looking and feeling my best. And don't sleep on the details. The pockets, the features, the finishing touches, everything has a purpose, and it makes a real difference when you're moving nonstop. The fit is clean, tailored, and super polished, and they come in a huge range of colors. In other words, they feel great throughout a 12-hour shift, and they always look good. See every healthcare professional on Instagram. If you work in healthcare or know someone who does, check out Figs and get 15% off your first order at wearfigs.com with code FIGSRX. That's wearfigs.com, code FIGSRX.
With the new My Lowe's Pro Rewards American Express card, earn 3 points per dollar spent on Lowe's qualifying purchases for the first 6 months after card account opening. Plus, save 5% every day on eligible purchases at Lowe's and earn points on eligible purchases everywhere else Amex is accepted. Card members get more at Lowe's. Subject to credit approval. 5% can't be combined with any other offer. Exclusions and restrictions apply. Points subject to loyalty terms at Lowe's.com/terms and credit reward terms at Synchrony.com/MLPRA-terms. Visit Lowe's.com/business credit.
I think if we had waited for permission to do everything that we did, our system would be crappier and we would have accomplished a fair bit less. Don't go totally rogue, but in the spirit of, a podcast called Rebel, I think it's worth being a little bit outside the fold and saying, if you're somebody in your department that wants to fix something, take it on, fix it, find a decent solution. It doesn't have to be perfect, ideate and iterate on that solution.
Welcome to Rebel Mind, a new series from Rebel EM, where MIND stands for Mastering Internal Negativity During Difficulty. In this space, we're focused on productivity, provider performance, and team optimization, so you can be your best at home or on shift when making difficult decisions under pressure. Today, we're diving into a term you may or may not have heard of, and that's human factors. When we talk about emergency medicine and the excellence of doing emergency medicine, we often think about knowledge, procedures, protocols, but today we're going to dive a little deeper into the hidden architecture that holds it all together. Joining me today are two master educators in emergency medicine, and they're experts in this field. The first is Dr. Chris Hicks. He's an emergency physician and trauma team leader at St. Michael's Hospital in Toronto. He's the assistant professor in the Department of Emergency Medicine at the University of Toronto and co-founder of Advanced Performance, a physician-led simulation and design group. Chris, it's great to have you back on Rebel.
Mark, it's great to be back again. Thank you for having us.
Next is Dr. Andrew Petrosoniak. He's an emergency physician and trauma team leader at St. Michael's Hospital and the medical director of the Unity Health Toronto Simulation Program. He's an assistant professor at the University of Toronto, where his research focuses on simulation for systems and design improvement and optimizing the care of the bleeding patient. He's also the president of Advanced Performance Healthcare Design, a consultant firm that works with high-performance teams and uses simulation to enhance and design better healthcare spaces. Andrew, it's great to have you also on the podcast. Thanks for joining us.
Yeah, Mark, thanks for having me.
So let's start at the foundation. And we were kind of chatting a little bit about this before we started recording, but human factors is a term that gets tossed around a lot, and it's often a very big catch-all term that may or may not be misunderstood. How do you define human factors in the context of healthcare and the emergency department?
It's an all-encompassing and I would say perhaps vaguely misunderstood term as well. Like we talk about human factors, really all the work we do is related to human behavior, subject to human error, subject to misinterpretations and interpretations, as you've seen, as you're saying, we were talking about this beforehand. Very high-performing, intelligent, effective people can make very peculiar and difficult to understand decisions when the ambient conditions are varied against success, I would say. I think the best way that I've tried to come to understand human factors, because it's such a broad phrase, is if your listeners think about what their medical practice is, they think, I think broadly speaking, about textbooks, medical knowledge, procedural knowledge, everything you learn in medical school, everything you think is going to make you, a competent physician, a competent doctor. I don't know about you or your listeners, but when I came out of medical school and then again came out of residency, it was pretty obvious to me that actually wasn't the hard stuff. It was everything beyond the sort of technical and procedural and content knowledge that I found really, really difficult. And interestingly enough, it's the stuff that you get the least amount of education on. So to try and define what human factors is to try and understand how you take the application of that medical, technical, procedural knowledge and apply it to a specific task, in this case, patient care or the care of multiple patients or whatever that happens to be, because there's an enormous amount of distance where the rubber has to meet the proverbial road from taking, say, the ability to do a central line, which you, me, all of your listeners could probably describe in pieces, sitting in a quiet room, reflecting to themselves. But to do that on a crashing or a resting patient who you're trying to get, set up and cannulated for ECMO, let's make them a pediatric patient in a chaotic room where you don't see a lot of peds, in an environment that's not well set up, that's not well lit, that's not well spaced, performing a procedure that you don't do very often or you haven't had very good refresher training in, with a high degree of stress and a hand that's shaking as you try to complete the procedure. That's human factors. That's everything other than the procedure that makes the procedure actually difficult. Lots of people, but Andrew and I in particular, have spent a lot of time trying to understand how we can teach and educate and understand everything that interposes between medical and technical knowledge and the application of that knowledge to patient care.
Yeah, that's a very difficult term to kind of put into a concise definition. I mean, Andrew, do you have anything to add, to mold, change, or edit about that?
I mean, I think where Chris is going with it is all the other stuff that you don't find necessarily in most textbooks. It's the interaction of the human with the system, with the environment, and then interaction with other humans. So that's kind of how I think about it. How are we, if you were going to use a central line example, how can we do that work, but not just actually put, a needle into through the skin? It's like, how do we get set up? How do we interact with a team? How do we manage an agitated patient? All of those elements are what makes healthcare complex. And it's that human factors piece that, we use that term. I think we kind of, it's broadly applied, but as Chris mentioned, fairly misunderstood. But it's that element, the link between design of systems, spaces, and human performance.
One thing I've heard you both say quite a bit is the system and spaces. And what I'm curious about is how much overlap is there in adult learning? And I'm pretty passionate about medical education and adult learning. So I'm wondering, is it kind of a little bit of mix of the system and what you can choose to change in the system, and then how much you can try to change in the human? Where does it, I guess, the boundaries stop on either one, if at all?
I can start into that, Andrew. I think what Andrew has taught me in our 10 years or so of working together on this has been really instrumental in helping me understand the interface between what you can teach a person and what you sort of have to force or compel them to do or to understand about the environment. There is a certain amount that you can educate people, I think, on their own response, say, to a stressful situation, or their own understanding of how their sort of innate human nature impacts their performance. And Mark probably already know this, but I mean, me and others have spent a fair bit of time trying to understand, for example, how one's stress response or emotions or their ability or inability to communicate, the so-called non-technical skills of team performance, actually play into how well they're able to execute in a high-pressure situation. That information is not new, nor do I think it should be ignored. However, I think what we both come to understand, and Andrew's helped me a lot with trying to understand this over time, is you can only teach people so far into, I guess, what you call ideal or preferred behavior in let's say, we're talking about crisis situations here. So let's talk about a crisis or a high stress situation. You can teach people a certain amount and you can help them understand a certain amount about human behavior, human performance, and team performance. But in the end, what you also have to do, and perhaps even maybe more effective than just teaching them, is make the preferred behavior the easiest thing to do. That is to say, if you want people to, so let's say, put in a femoral art line in cardiac arrest because you at your institution have come to understand that fem art lines are really helpful in targeting post-resuscitation goals. If you want to do that, you can't just sort of tell people that that's the way it needs to be done. You need to make that default behavior the easiest thing to do by creating procedure bundles, by creating work surfaces and carts that allow for that sort of behavior. If you simply teach people that, they won't necessarily get to it. They won't necessarily reach to that or aspire to that if it's the most difficult thing in the given circumstance to actually execute. So the environment and how you set up the system, we've talked about this, so we can break down a little bit about what we mean by that. has to enable the sort of things that you're trying to teach adults to be able to do in order to make it actually effective.
Mark, I think there's a quote from James Clear, the author of Atomic Habits. I'm
Great
sure,
book, by the way.
yeah,
Yep.
it's a great book.
Mhm.
And it's one of my favorite quotes is the environment is the invisible hand that shapes human behavior. And
Nice.
so building on what Chris said, we strongly believe that, if you want that art line to be put in, don't make it so that every time the clinician has to go find all the equipment. Resuscitation inertia is sort of a term that we use to describe a team resuscitating a patient, that a team will want to do whatever it's been doing, so if you can easily shift a team into action, then it'll continue to act. If they're stagnant because they can't overcome whatever the systemic encumbrances are, then it's going to be challenging for them. When you think about a F1 team doing a pit stop, they can change 4 tires in 2 seconds, which is unbelievable, right? They're obviously very skilled, that team, at what they do, but they have every piece of equipment perfectly placed so that there's not 1 millisecond of waste. If we transpose that same team and put them into my driveway, they certainly would be faster than I would be. And, if left to me and Chris to change tires in my driveway, then we'd probably take us still about a half an hour to change 4 tires. I bet you that team, an F1 team could probably do it in a few minutes, but they couldn't do 2 seconds because, I don't have an F1 pit stop in my driveway. So it sort of highlights the importance, and something that we've probably underappreciated in both education and design. You're talking about how do you educate people better? Well, I'd love to spend less time educating people on where equipment is placed in a room and more time on how does a team actually work. But instead, in healthcare, because we design spaces so poorly and lay things out so poorly, we spend a bunch of time wasted on, hey, you got to remember in this stressful event that the central line bundle is over in the left-hand corner up above that piece of equipment behind the urinals. That just doesn't make any sense.
Down. Yeah, totally.
I think, and this gets back to the idea of why human factors as a phrase is, in my mind, such a peculiar one, because we think of it as something extraneous to the work that we do. It's such an odd thing to consider that the people and the teams within a given care delivery system are somehow extraneous to the system itself. They're not. And yet we've become so helpless. We have such a sense of learned helplessness in the way our systems are designed. I think we just take it for granted that that's how work ought to be done. And maybe the best example I can give, Andrew and I were just writing a chapter on this. Andrew, I don't know if I'm quoting you or somebody else when I say this, but the notion of sort of preparation by way of policy is, talk about healthcare. That's that is the quintessential notion of understanding how we think healthcare preparation ought to be delivered, which is we have a policy and we have a flow chart and we print a flow chart and we put it on the wall and we imagine that people are going to follow that. And then we get really frustrated when in a given situation, people don't follow that to a letter. Well, why is that? Well, that's human behavior. That's stress. That's interpersonal relationships. That's socio-evaluative stressors. That's imposter anxiety and difficulty with understanding your own role within a team. And it's where is all the equipment and why doesn't the room function? And that policy is stupid in the first place. And I hate the person at the other end of the room. And all of those things that we somehow, again, have sort of, I think, come to understand as being extraneous to care delivery, which really are at the core and are essential to and really not separate from, but are deeply embedded within the sort of care delivery that we hope or aspire towards. That Andrew and I would say you really have to think of it as sort of a design cycle with individuals and equipment and teams and spaces and systems all developed within something that looks a little bit more cyclic, as opposed to, well, we want to deliver this care and now we're going to deliver this space and now we're going to create this equipment and all of them are going to get developed in silos. And then you, the doctor, and the team are going to need to figure out a way to put that together. That sounds like what healthcare delivery actually is. And I think our thesis is that's not what healthcare delivery ought to be. That human element that's core to care delivery, to effective care delivery, to that F1 team that Petra referenced a second ago. That's really what we need to be thinking about when we talk about effective human factor design.
So you both said something that I'm going to touch on. The first was, Petra, you talked about like a resuscitation inertia, and that often reminds me of sonography inertia. As an ultrasound person, if a patient comes in, you going to do that scan after you've already seen the patient is so much harder than if you were to take the ultrasound machine in the room with you on that belly pain, right? It's actually quite of a similar mentality. So that was an interesting point. And Chris, you touched upon a point that I kind of want to elaborate on when you said the statement, I hate that person on the other side of the room. Obviously, politics and personality play a huge role in this. So, how much do you alter when designing these spaces? How much do you alter the space or modify these plans or the architecture around one particular person of maybe power or not, or title or not, who is irreplaceable? So like an example is trauma surgeon or a cardiac surgeon who's just like not getting it or refusing to work with the systems that have been designed, but you can't really replace this person. Like, what do you do, or what kind of advice would you have to modifying this for that particular situation or scenario?
It's a great
Chris
question.
would
I don't
design
know if I have.
out me being there. You would, right, Chris? You would
Well, that's what I
design
would
me
say. I'd say we've designed this sort of poorly marked space on the floor, which is actually a trapdoor. We press a button, they disappear.
There you go. They fall right
Um,
through and then you don't have to deal with them. That's actually even better.
I'd also say that it would be the emergency medicine doctor that's irreplaceable on a team, maybe not a trauma surgeon, but that's an unrelated
Fair
point.
enough.
Um,
Fair enough. That's a good point.
I think the point's a very fair one though. So how do you make a team? Let's imagine a scenario where there is a team within which there is some degree of inherent conflict or even just disagreement. It doesn't have to be personalities. It could be a disagreement about clinical course or next steps. I mean, it's an everyday occurrence in healthcare. How do you design to enable that team to still perform? There are lots of environmental design cues that can either raise or lower a team's level of stress and or performance. We take them for granted mostly because they're not there most of the time, that we don't even necessarily think of what they are. And if you take a team that's maybe a baseline, let's say there's an interpersonal conflict or a conflict about decision making, and then you make that room loud and you make an excessive degree of ambient noise, you make it cramped, you make sightlines difficult, you make whatever has to happen in terms of patient care difficult, how much easier does it become to resolve an interpersonal or behavior or team-based conflict? Again, it's like taking something that's simmering and you turn the heat up to the point where it becomes a pressure cooker. So I don't have a way to design out interpersonal conflicts. However, I mean, we can take the example of the trauma room at St. Michael's, which Andrew and I used a lot of simulation-informed or immersive design to help create. We were very deliberate about identifying, for example, ambient noise in the background. We were very deliberate about creating a circle of care in space, a 6-foot radius centered around the chest that needs to be kept free at all times for patient care. We were deliberate about floor markings and where people can stand so that people don't get crowded and bumped and nudged and sterile corridors don't get violated and those sorts of things. Sightlines to monitors. Again, another one of Petra's personal pet peeves and mine. You're intubating a patient. Why do you need to crane your neck around to look behind you like everywhere else in the world to see that the patient's desaturating? We put monitors at the foot of the bed and the side of the bed so that you don't have to do that. Little things like that. I wish we bothered to measure it, but we never did. We designed the trauma room and then COVID hit. So our ability to sort of do post-occupancy measurements kind of fell away. But I would contest, or I would be willing to bet that when you set an environment up like that, where you're not turning the pressure cooker heat up by making the environment just that much more easy, that much more straightforward, that much less difficult to work in, whatever interpersonal conflicts become or management conflicts become a lot easier to manage because you're not adding that underlying additional stress. And again, you think about it at home, right? Like how easy is it to get along with your family, your kids, when everything is falling over in the background and you're banging into stuff and pots and pans are clanging. We all understand intuitively what this does to our affect and our behavior and our ability to perform. And yet for work, when we're at work, we somehow take it for granted that that's how the environment ought to be. So I think when you start to design with some of those things in mind and try and subtract them out, the permissibility of the work environment and the ability to deliver effective high performance care gets better.
And I think we focus a lot on how do we eliminate interpersonal conflict. I think it's too predictable to occur that we should rather think about it as how do we manage it. Just like complexity within the healthcare system, it's just not a possible thing to do. The best approach is to manage it. How can you manage it? Well, you can do other things to reduce its frequency from occurring, meaning, the interpersonal conflicts, like Chris said, manage that you can't really control how another person's going to behave. You don't know what, interaction they just had, how sleep deprived they are or whatever, so in the moment, it's impossible to manage all of that. At a system level, you can design call schedules better so that when people come together, they're less tired, they're less likely to be angry, and they'll be able to manage stress better. It's a multi-pronged thing. So make the space welcoming, make the space, tolerable for those working in it, make them be able to find equipment that they need. All of these things can be dealt with. And then as the byproduct of that is that the probability of interpersonal conflict will go down, but it should never be thought of as going away. Some of it is quite healthy. You want people to be able to be challenged. You want people to be able to speak up. It's just a matter of how that actually happens. Certainly there's unhealthy ways of speaking up and healthy ways of doing so, but understand that people will react perhaps in ways they might regret in the moment. But if you can create a space so that it's not just constant pots and pans banging, you can maybe walk back and actually have a real-time apology even in a moment and say, yeah, sorry about that. Let's keep moving.
Yeah, it's a great point. Now, I'm so glad you guys brought up the trauma resuscitation room at St. Michael's because I saw pictures from it. I don't remember. I'm sure it's probably from one of your lectures somewhere. And you guys have a whole area designated for like chest tube cart. You have a whole area designated for different equipment. We'll try to include some of those photos in the blog post just so that our listeners can better visualize what I'm talking about. But what I want to ask is, what can the physician do who can't control that environment or can't control the design of that room? So an example is like my CTICU is now been created. I can't move and put in carts and put in fun stuff that makes it easier to open a chest. What next steps, or how would I approach either leadership, or what can I do to kind of move in that direction of improving design to better improve outcomes for when those high stress moments come?
I mean, I could start with, so outside of our trauma bay, we had a pediatric resuscitation cart that was built off a Broslow model, which in theory was quite good, but we're not a pediatric hospital, so we don't see that many patients, but anything that was pediatric would just get thrown onto this resuscitation cart. So you'd have like pediatric Foley catheters, you'd have warmers. It was just like a mess. And you can imagine the stress that it would elicit. I mean, first of all, it's stressful to resuscitate any pediatric patient.
Yeah.
I think more, especially when you're unfamiliar with that. So that stress is right there. But if you have a better design cart, at least you can do the things you know to do. I need to be able to get IV access. I need to be able to put get vital signs, and then I can kind of move forward. It allows for resuscitation inertia to kind of happen. You want to be in an inertia state of movement forward in that case. So it doesn't take that much. You can find a cart in your hospital that can act as a prototype. This is kind of the principles of design thinking. Just build something that you think will align with some of the way in which you work. So I built a prototype of this cart, so we had our existing cart. Chris and I, kicked around some ideas, how he had built already adult resuscitation carts in our trauma bay. We borrowed all of those same kind of principles, put something together, and then I just ran like mini usability testing simulations. So I just grabbed a nurse or a doc on shift with a mannequin, like a child mannequin, put it in a room and said, I just need you to do these 4 tasks. And then I would just time it. And then we would have them do it using one cart and then the other. And I would just collect the data. It took me, I don't know, a couple of days. This was not published data, but it was used then to go to our leadership and say, look at the time difference it takes if we use cart, the existing cart or the new prototyped cart. The time difference it takes to get IV access, to find the equipment for applying oxygen to a neonate, whatever. There's a bunch of tasks that we scripted out. It was not hard to do. And I just put it into an Excel file. We then had a bunch of data, and then I could go to leadership and say, well, here's a difference. You guys now can decide if that's a difference that you're interested in. But personally, I think having a couple minutes difference in getting vital signs or delivering oxygen to a hypoxic child, that's going to be meaningful at some point that I think our hospital deserves to move on. And that's what we did. And so having a bit of data, but people, I think, get overwhelmed. It's like, how am I going to do this? This is just sort of a bit of guerrilla usability testing. You don't need an N of 100 people, I don't know, I think I did like 20 or something like that. You get enough data to convince people, because what do they have prior to that? Like the decision to buy the shitty cart was, zero data. So I think we're in a better spot. And, as a result, it's now a better way of managing.
And I think for your listeners, I mean, you're asking how does somebody who hasn't done this before get started? I mean, finding a problem is not going to be hard. Like you can walk into any emergency department,
very true.
ICU, anywhere, get a small working group together. This is going back. Andrew's selling himself short a little bit. Like he did the background work to figure out that the PEEP card was a problem, and it was. But of course, you could swing a dead cat over your head in our department and you would hit something that was a problem. But that's probably true pretty much anywhere. So start with something that people can identify as a problem, get a small little interdisciplinary group together. This, by the way, when we talk about human factors, this is human factors design. You get people together to think about and ideate on problems and solutions. And then you, as Andrew said, you guerrilla test or you iterate design solutions to solve those problems. I think the message that Andrew is delivering, and I think it's an important one, is start small. But when you talk about starting small, it also means don't let your solutions fall to sort of death by committee either. So, to a certain extent, if you try and build a big solution up, I'm going to engage my hospital patient safety team and I'm going to get a bunch of committees together, then it's going to go through mountains of paperwork and people are going to wring their hands about it. And some lawyer somewhere is going to like your idea and then it's going to die. Andrew and I have found more success, maybe makes us less popular, but we found more success, as Andrew said, in just sort of showing people good solutions and daring them to say no to those good solutions. That, in our experience, has been a more effective way to get things done. I think if we had waited for permission to do everything that we did, our system would be crappier and we would have accomplished a fair bit less. Don't go totally rogue, but in the spirit of, a podcast called Rebel, I think it's worth being a little bit outside the fold and saying, if you're somebody in your department that wants to fix something, take it on, fix it, find a decent solution. Doesn't have to be perfect, ideate and iterate on that solution and then work on putting it into practice. And people can do their best to say no to a good idea, but that's awfully hard to do once you've demonstrated some degree of proof and concept.
Yeah, I think one important thing to highlight too is you both have a degree of flexibility and adaptability. And I would even argue some humility to know when your idea may not be working or when things aren't panning out. Not everybody has that. And so, how or what advice would you give to someone who may have trouble letting go of their idea if they've already invested a lot of time, invested a lot of work and energy getting this to committees, has maybe created a couple of policies and protocols? And now it's that notion of like, how much do you force it? Or if you even know you should force it versus, no, this isn't working. We need to pivot and turn and do something else that might end up working.
Yeah, I mean, I think, some of that you're kind of getting at a bit of a sunk cost fallacy that happens is that people keep doubling down on bad decisions. You buy tickets to go to a concert and then there's a snowstorm. Well, we're up here in Canada, so that's not uncommon. You bought the tickets, you've paid the money. Now, if you go and make a bad decision by driving 2 hours to get to that concert in an unsafe environment, well, that just doesn't make a lot of sense. You've already bought the tickets. That cost is sunk. So the fallacy is, well, because I bought the tickets, I got to go to the concert. So the same is with equipment. And how do you, or, a design process, how do you have an off ramp? I think this applies, whether you're running a resuscitation or building carts. It's fairly predictable, not all problems that arise, but many that, the cart might not work. I may not be able to get the equipment in time. And you should build in some signpost, we call it signpost decision making. So, if you're intubating a patient, you should say out loud, if I get to 80% O2 saturation, then I'm going to stop the intubation because I need to reoxygenate the patient. But you shouldn't do that in the moment, because in the moment you're going to say, no, I'm almost there. Like the tube's just about to pass and you're emotionally invested. What you really want to say is, before you start the procedure, pick a number that you want to have an off ramp, and your team will hold you accountable. Say, you said at 90%, you're going to stop intubation. Well, the same can apply with a design process. Like, hey, this is what we're going to try and achieve. But if we're not here by this date, then we're going to pivot. Or if we can't achieve, getting O2 to a neonate using this cart in under 10 seconds, then we have to redesign it. So you put in some predefined metrics or signpost decision making so that you don't fall victim forever to the sunk cost fallacy.
Yeah, and I think that's incredibly important, having something to sort of wayfind your decision making, for lack of a better phrase. So you're not wayfinding completely in the dark with no clear endpoint. I think the other thing that's important when you're talking about human factors design, let's take the carts again for an example. These weren't a bunch of doctors sitting around in a room in an echo chamber trying to figure out what works for them. These were interdisciplinary teams, small interdisciplinary teams of people saying, if you're in a resuscitation and your resuscitation involves doctors, nurses, respiratory therapists, what we call CAs, clinical assistants, whose job it is to get equipment for you. You need all of their input to come up with a good design solution for a particular human factors or team problem. So you seek input from those people, but it's important to have a team around you that you trust that can provide that sort of input and can sort of check you if the design is going sideways or really not, as you say, sort of delivering on what it is you want it to deliver on. But again, you don't want it to be too big. You talk about getting discouraged. I think people get discouraged. As you say, Mark, you're talking about, sort of scaling this up to committees and writing process and protocols. Yeah, problems often do have to get there. But I'd be willing to bet 90% of good ideas die somewhere in that process because the process that they're subject to, it kills them rather than they get killed because they're not good ideas. So, having a small team around you that you trust that can give you meaningful feedback, you can't get too married to your own ideas, and having some signposts or wayfinding to help you understand whether your decisions are good or not. And we keep saying this, and I think it's important. You got to keep the process relatively small on every level. Again, you're talking about getting started. These sorts of design ideas can scale all the way up to the creation of a new hospital network, right? Like,
Right.
They don't have to be small, but if you're talking about starting small, having a small group of people who you trust, who can check you along in the process, and not taking every idea to some committee where it's going to sit there for 18 months and then eventually just fall off the table, is an effective way to move forward. It's also important to make sure people understand the output of your process as well. So if you want to build on the work that you're doing, let's take Andrew's PEDS resus cart as an example. Everyone in the department could tell you that when a sick kid rolled into our department, it was going to be a nightmare to look after them, in part because of equipment and logistic limitations. Well, now that you've got this piece of equipment that makes it a whole lot easier, you have to make sure people don't understand that, because if they've just gone through this process with you to sort of design a new PEDS cart, it's important that everyone then understands why that cart is actually going to make their life and their job easier, not in some abstract way, but in some concrete sense of like, okay, let's do a simulation to try a PEDS resus and let's look at how much easier it is. People then really have this aha moment of like, aha, this sort of human factors design thing is kind of important. Altruistically, great. It makes patient care better, but honestly, it just makes my life easier and it makes the care that I deliver easier. And this work is not harder. It's now easier because of this work that's been done. And if you want to build momentum for that sort of thing, those people, the department leaders, people that have the purse strings on these sorts of decisions, they need to see it too. Because then they also say, okay, well, this makes work easier, not better. Ideally, it makes it cheaper, not more expensive. Let's figure out how to move forward with the next project exactly like this. And that's how you build momentum moving forward.
That's a great point. I think that as a result of this conversation, I feel like there's so many other different directions we could go in different future episodes. So I really thank you both for joining me today and really diving deep into this discussion.
It was great to be on, Mark. Thank you for having us.
Yeah, of course. Absolutely. Well, that's it for this episode of Rebel Mind. Subscribe, share, and stay tuned as we dive deeper into practical ways to care for ourselves so we can show up and take care of others.